So welcome everyone. We want to do microbiology spot. So hope we're going to engage and discuss a lot. So let's start. Question 1, a stained smear from a patient with a history of chronic cough. So here is the stain. Okay. Here is the stain. You can see these pink lines that you can see here are the bacteria. So identify the staining technique giving reasons. So what staining technique is this? Yeah. Who knows?
Is it Zeus staining? Zeus-Nelson staining?
Zeus-Nelson staining, yeah. So if you know the answer, you can also type on the chat so that we move a little bit quicker since you were able to go through the paper. So this is Zeden staining or Zeus-Nelson staining. So if you're told give reasons, you have to mention why you think it's a Zeden staining. So a Zeden staining is very, very specific. What happens is we have a blue background, and then you're going to see these bacteria, which is Mycobacterium, okay? And it usually stains the pink. It appears pink. These are pink bacilli, okay? You remember bacillus? We have the rods, which are the bacilli, and then we have the coccus, which are the ones that are circular in nature, okay? Then identify the most likely diagnosis. If this is, we already know it is Mycobacterium. So from a patient with the history of chronic cough, what is the diagnosis? Tuberculosis, okay? So it's good you mentioned pulmonary TB because TB can manifest itself in various ways. So here we're talking about pulmonary TB. Then name other bacteria that stain positive with the above stain. So there are quite a few. So you mentioned the mycobacteria. We have mycobacteria tuberculosis. We have Mycobacteria leprae, that causes leprosy. We have Mycobacterium marinium. We have, let me see answers in the chat. Mycobacterium bovis, yes. Okay, there's also Nocardia species. Okay. Then, apart from chronic cough, identify other clinical features associated with infection with the organism. Okay. What do you think? So we've been asked clinical features of pulmonary TB. What are others?
So you have fevers, night sweats, loss of weight.
Good. So we have fevers, night sweats, loss of weight, fatigue. Okay. So we see the answers. Okay. So we have Zn, pink rod-shaped bacilli in a blue background, mycopulmonary TB, Nocardia species, M. leprae, MAC, M. marinium. You can also add M. bovis. MAC means Mycobacterium avium complex. Okay. Put my laser here. Mycobacterium avium complex. Then we have Mycobacterium marinium. We have fever, unintentional weight loss, night sweats, hemoptysis. Hemoptysis means that you're coughing out blood, okay? Or the sputum that you cough has blood streaks. We have malaise, which means basically fatigue, chest pain, and decreased appetite. Then name 2 alternative staining techniques to identify this organism. There are actually three or four, around 4 staining techniques that we use to stain pulmonary to stain TB. Which are they?
Nucleic acid amplification tests.
Nucleic acid? No. We want the staining techniques, not lab techniques. So I'm seeing from the chart we have quinone. Quinone is there. Aramine, phenol, that is there. Rhodamine, aramine stain, yes. Silver stain, no, we don't use silver stain in TB. Where is silver stain used? Where do you use silver stain? Treponema. So syphilis, yes, we have treponema. That's where we use the silver stain. Okay, but it can also be used in fungi. You can remember things like Cryptococcus, Candida. We can use the silver stain. Okay. Identify the 4 drugs used in treatment of this disease in the intensive phase. So this is a very common question. You'll also see it in the MCQs. Okay. What are the drugs? The mnemonic is usually RIPE. What does RIPE stand for?
I think we have rifampicin, isoniazid, parazinamide, and ethambutol.
Ethambutol, very good. That is the mnemonic. Rifampicin, isoniazid, pyrazinamide, and ethambutol. That one is a must know. Okay. It is a must know. Then describe the immune response involved in controlling primary infection. So we can go through that together. So quinone, aramine, rhodamine, rifampicin, isoniazid, ethambutol, and pyrazinamide. So for the immune response, this was supposed to be, I think, 3 marks. We have the innate immune response. When we say innate, this means that it is natural. Okay. So you're going to inhale the TB. Okay. So I want you guys to listen to me. You're going to inhale the TB, the bacteria. Now, TB is very, specific because it hides itself. It tries and evades the immune system by hiding within the macrophages. Okay. So it's going to be engulfed by the alveolar macrophages. However, the TB resist intracellular killing due to their waxy cell wall and replicate within the macrophages. So as I was saying, it hides itself within the macrophages. And while in the macrophages, other immune responses won't be able to penetrate the macrophages and get to the TB. Okay. Then we have the cell-mediated immunity. So cell-mediated immunity deals with T helper cells. Okay. So this occurs within 2 to 4 weeks. Dendritic cells, which are antigen-presenting cells, they present TB antigens to CD4 T helper cells. Okay. Then you're going to release interferon gamma, and then these are the cytokines. Now, these cytokines, they activate the macrophages to enhance their killing ability. So here, what you're going to say, if you can't remember all this immunology, you can just mention 2 to 4 weeks after infection, cell-mediated immunity is activated, leading to enhanced killing of the TB. Then after that, there's going to be formation of granuloma. So these are the marking points. Granuloma formation is very, very important. Okay, and for TB, they usually call it caseating granuloma. What that means is on the appearance of the lung, it looks, caseating means, or caseating means cheese-like appearance. Okay, so what happens is a granuloma is going to be formed. And in this granuloma, there are very many things. It is composed of the macrophages, epithelial cells, Langerhans giant cells, and lymphocytes. Basically, all the immune cells come, fight off that TB. leading to formation of this granuloma. Okay. Now this walls off the bacteria and prevents dissemination. Dissemination means spread, resulting in latent TB in most healthy individuals. So if you have, a great immune system and you're not immunocompromised, you will not get symptoms of TB. It will remain latent in your body. But when you get immunocompromised, for example, in a HIV patient, this latent TB will be activated. Okay. Then when it is activated is when now you start presenting with other signs and symptoms of TB. Okay. So the marking points, if you're asked about immune response in controlling TB, you have to mention the innate, where it goes and hides within the macrophages. Then cell-mediated immunity is going to be activated, leading to granuloma formation. I hope that's clear. So this is something which is very good to know because it can also come in an essay. Okay. Then we go to number 2. So you can see the appearance of this guy. Identify the presentation above and the bacteria that causes it. Okay. So I'm seeing a question on the chat. They've asked, what's a GON complex? So yeah, that's a very good question. I didn't want to get into like so much details because that's more of pathology, but we can go back to the TB. Now, you see what happens is TB mainly affects 2 places in the lungs. We have the hilar lymph nodes. They're usually the lymph nodes that line the bronchioles, okay? And the lobes of the lung, okay? Now, what happens is when these macrophages are going to be, they have engulfed the TB and cell-mediated immunity has occurred, there's going to be formation of the granuloma. Now, this granuloma is what is going to lead to the formation of the GON complex. So there are terms here. There's a term where we say GON foci or GON focus. A GON focus is a granuloma on the lobe of the lung. But when it affects the hilar lymph nodes, which are the lymph nodes lining the bronchioles, is when we call it a GON complex, because you have affected the lungs, the lobes of the lungs, plus the hilar lymph nodes. That is what we refer to as a GON complex. Now, this GON complex, it can be calcified, okay? Calcification is going to occur, leading to the formation of something known as a Ranke complex. Okay, so this is a lot of pathology, but it's very important for you to understand. So the GON focus is the granuloma formation within the lobe. Then if it affects the hilar lymph nodes, it becomes a GON complex. If it becomes calcified, it becomes a Ranke complex. Now, what happens is, remember, the immune system is continuously fighting. When it continues, it's going to lead to the formation of a cavitation. Basically, think of it like you're scooping sand. You know how you can scoop sand and you leave a cavity or a vacuum within. Now, it's with continued immune, activation and more destruction leads to the formation of those cavitations. Okay. Now, a good thing I can tie in with that cavitation is, can you remember what fungus occupies the cavitations left behind by TB? I think I had mentioned when we were doing mycology. Can you guys remember?
Aspergillosis.
Yes, aspergillus. The fungus aspergillus, leading to aspergillosis. Okay, very good. So that's how it occurs. So in a patient who presents with hemoptysis and they had TB, think of aspergillosis, because those fungi have gone and occupied the cavitation left behind by TB. Okay, I hope that's clear.
Yes.
Thank you. So identify the above presentation and the bacteria that causes it. Then this is very specific. This image, you can see this guy has some lumps and some nodules on the face. Then identify the primary mode of transmission. Why can't the above organism be cultured in vitro? Identify the two forms of the disease caused by the microorganism and state their differences, and then drugs used for treatment. Okay. So what is this presentation called? Answers in the chat. So lepromatous leprosy. Yes, it is actually lepromatous leprosy, but the presentation is not lepromatous leprosy. Lepromatous leprosy is one of the forms of leprosy. Okay. So this presentation is known as lion-like, or lion-like presentation. You see, this guy looks like a lion. Can you see this? We call it leonine faces. Okay, that is the name of the presentation. Then if you're asked about the bacteria, it is M. leprae, Mycobacterium leprae. If you're asked the form of the disease or the disease, it is lepromatous leprosy. So please take note of that. There are different terms that they can use, so please don't get confused. Don't rush to answer these questions like that. I want you to take time and answer and understand. Okay. Yeah. Now, primary mode of transmission. How is leprosy transmitted? How do you transmit leprosy? Airborne, yes. So inhalation of nasal droplets, that's good. Contact. Yes, so what happens is if you have prolonged contact with a patient, you can get leprosy. Then it's also spread via the respiratory droplets. Okay. Why can't the organism be cultured? So prolonged close contact, mainly via resp droplets. Why can't it be cultured? So it's an obligate intracellular organism, and it grows very slowly. That's why you can't culture it in vitro. Okay. And then the next question was identify the two forms. So the two forms are lepromatous and tuberculoid. Then state their differences. So I had a table here. Yeah, this is a very good table. So this is very, very important because it can be present in both MCQs, SAQs, and even an essay where you're told to compare and contrast the two forms of leprosy. Now, we have tuberculoid and lepromatous. The one we have seen where it presents with the lion-like faces is lepromatous type. So tuberculoid is I usually compare it to the less form or the less severe form of leprosy, tuberculoid. Then lepromatous is the more severe one. Now let's see. Immune response. Tuberculoid is a strong cell-mediated immunity mediated by T helper 1 cells. Lepromatous is poorly cell-mediated, mediated by T helper 2 cells. Okay. Lepromin skin test. Okay. For lepromin skin test, this one turns positive, this one turns negative due to the strong cell-mediated immunity. So that's why you'll be able to get the antibodies against it. So that's why it's positive. Skin lesions. For tuberculoid, there are few well-defined hypopigmented patches. In lepromatous, there are numerous, poorly defined symmetric lesions. You can see these ones. Look at how many there are. Quite a few. And they're poorly defined. Like you cannot know where this lesion ends. You can see this one, it looks like this. This one is small. This one is a large one. So it's poorly defined, but they're very numerous. You can see in this man, he has quite a few. Sensations in lesions. The tuberculoid are markedly reduced or absent. These ones are less affected early, reduced later. Nerve involvement. We have, it is early, asymmetrical, and localized. For lepromatous type, late, symmetrical, and widespread. For here, they have few bacilli. It's usually referred to as paucibacillary. And for this, in the nerves, there is numerous bacilli. Histology, these ones you're going to see granulomas with Langerhans giant cells. You see it is similar to Mycobacterium TB. For lepromatous, it's the foam cells with numerous bacilli. Infectivity, this is low, this is high. Facial in tuberculoids, very rare. Facial, so here you can say facial appearance or facial lesions. In lepromatous, it's very common. Okay. So in summary, because you have to know these differences, just remember that tuberculoid, highly cell-mediated immunity, and a low bacterial, it's low, a low bacterial load. Okay. Then for lepromatous, low cell-mediated, leon-like faces or leonine faces, and then it is lethal. You can remember lepromatous is lethal, LL, so that you can remember. Okay, and it has a high bacterial load. Okay, that's in summary. That's how you remember these two. Okay. Now, what is the next question? Identify the drugs. So what are the drugs used for treatment of leprosy? So I wasn't specific. I would have asked, what are the drugs used for lepromatous? What are the drugs used for tuberculoid? But in general, what are the drugs used? Dapsone, yes, good. We have Dapsone. Another one? Clofazimine, good. There's also rifampicin, very good. So Dapsone and rifampicin for tuberculoid. You see, it's quite similar for, you see, tuberculoid. You see, anytime you see an oid, oid means similar to, okay? So when it's tuberculoid, it means it is similar to the TB. Okay, so you use Dapsone and rifampicin. Then for lepromatous, you add in clofazimine. Good. Okay. This is a diarrheal stool isolate on selective media. Identify the media shown and name two components of the selective media. So you've already been told it is diarrheal stool. So this is a good thing because you can eliminate and think of the bacteria that cause diarrhea. Name two organisms that can grow in the above agar. Name two key features of the bacteria as seen under microscopy. Identify the type of toxin it produces and its mechanism of action. So first of all, what agar is this? Because if you don't know the agar, you will not get the question correct. Yes, what agar is this? It's very specific. Yellow, green background, and yellow pigments. What agar? Who knows? TCBS, very good. Thiosulfate, citrate, bile salts, agar. Then what are the components? So you've already mentioned the component. What are the components? What is seen in thiosulfate, citrate, bile salts, sucrose, agar? Sodium thiosulfate, citrate, yes, all those. Sucrose, bile salts, okay? Two organisms, this is very, very specific. We have cholera, okay? Vibrio cholera, we have the other types of Vibrio. So let's see. So TCBS agar, thiosulfate, citrate, bile salts, agar, sucrose, agar. The components, we have yeast extract, sucrose, bromothymol blue, sodium thiosulfate, agar, sodium chloride, etc. Now, thiosulfate is, the function of thiosulfate here is it produces sulfur, okay? So the production of sulfur here, it is used to detect if the hydrogen sulfide, okay? You remember in the acid alkaline bath, we have H2S production, okay? So if you see black, we'll know that that is not Vibrio cholerae, because Vibrio cholerae is gas negative. There is no production of hydrogen sulfide gas. Then for the citrate in TCBS, it's a chelating agent. What that means is it is going to kill other microorganisms apart from Vibrio. Okay, so any non-Vibrio species are going to die. Then the bile salts, anytime you see bile salts anywhere, it inhibits the growth of gram-positive bacteria. Okay. Then sucrose is just a source of energy because it's going to be fermented. It's a type of carbohydrate. So once it ferments, there's that production of the acid, and the acid is going to make it turn yellow. Okay. Then the bromothylol blue, I mean, it's the one that is going to eat. It's a pH indicator. So once acid is produced, it is going to get that yellowish appearance of the bacteria. Okay. Basically just a pH indicator. Yeah. Clear? Then two key features. So you've been asked key features of Vibrio species under microscopy. We have gram-negative, then flagellated comma-shaped bacteria. Identify the type of toxin. So this is very important. It's an enterotoxin, permanently activates adenylyl cyclase, leading to increased cyclic AMP levels, leading to massive chloride and water secretion, leading to rice water diarrhea. This is the mechanism of that toxin. Okay. This is very, very direct. Which other toxin did we say activates cyclic AMP? Do you guys remember? We mentioned two other toxins that activate cyclic AMP. Who remembers? ETEC, enterotoxigenic E. coli. Remember, it is the heat labile one because heat stable one is going to activate cyclic GMP. And then which other one? Sugar, really? Sugar toxin doesn't. Sugar toxin works by inhibiting protein synthesis. Which other one? Pertussis, yes. So pertussis is the other one. Okay, it increases the cyclic AMP levels. There's also bacillus. I was looking for another one, bacillus anthracis. Okay. Then the next question is, which bacterial serotypes are associated with epidemics? Clinical features associated with infection, apart from, diarrhea. Initial step in management of infection caused by the above bacteria, then mode of transmission. Okay, so which are the serogroups?
Zero one
01 and
0139.
0139. Good. Clinical features of cholera apart from diarrhea. Increased thirst, vomiting, dehydration. Yes, very good. And then we go to initial step of management. So remember, they've asked initial. What is the first thing you do? Fluid replacement. Very good, because you've lost a lot of fluid through the diarrhea and vomiting. Then mode of transmission. How do you transmit cholera? It's fecal-oral. Very good. So yeah, that was an easy slide. 01, 0139, fever, vomiting, profuse rice water diarrhea, oral rehydration therapy, fecal-oral route via contaminated water or food. Okay. Specimen from an ear swab. Okay. Identify the organism. This is only one organism that has this certain pattern. Key features on microscopy. 2 pigments produced by the above bacteria. Then you have to comment on the following lab diagnosis: urea, oxidase, and catalase. Okay. First of all, from an ear swab, this should have given you an answer. So most likely this is a bacteria that causes otitis media, isn't it? Which bacteria causes otitis media? Pseudomonas aeruginosa. Good. Now, key features. When you're asked about key features of a bacteria, it's just you have to mention what you see. Okay. So the fact that it's gram-negative, you have to mention. If the bacteria is motile or not motile, you have to mention. Okay. The shape of the bacteria, you have to mention, because those are the key features.
I have a question.
Yes.
Now, this question is asking, like specifically for here, it's asking features of the bacteria seen under microscopy. So, would you be able to see motility under microscopy, or could
Yeah. Yeah.
you would?
Would you be able to see under microscopy? Would you be able to see it's motile? I'm not sure, because unless I check, let me see. Let me see. Although I'm not sure.
Okay.
Can we see motility under microscopy? Yeah, you can actually see it.
Oh, okay.
Yeah.
Thank you.
Yeah, you can see. What I know is, you remember one of the bacteria, which bacteria am I thinking about? The highly motile one. Was it Listeria? Monocytogens? Do you remember Listeria monocytogens, which shows the, what is it? What's the name? Tumbling motility? Okay,
Yes.
so yeah, you can see it under microscopy.
But would that only apply to like Listeria because it has such high motility, and not for Pseudomonas?
I think now, when you're looking under light microscopy, if you are to see it via the gram stain, you won't be able to see if it's motile. If you do like a proper gram stain, you won't see if it's motile, because by the time all that time you've done, the bacteria is already dead. So you'll only identify the bacillus. So depending on the staining technique you use, because for Listeria monocytogen, yes, it is highly motile, and on light microscopy, you'll see that tumbling motion, how like it moves really, really fast. So it depends on the staining technique.
All right. Thank you.
Yeah. So I hope that's clear. So identify 2 pigments produced by the above bacteria. There are quite a few. If the names are hard, you can just mention the color of the pigments. Blue, green, red, brown pigments. Okay? Because they have, if the names are hard, pyovardine, pyocyanin, those ones, pyomelanin. Just mention the color of the pigments. And comment on the lab diagnosis, urease, oxidase, and catalase test. So here they are. So it's a gram-negative motile bacillus. Pyocyanin is the blue one. Pyovardine is green. Pyorubin is red. Pyomelanin is brown. It is urease negative, oxidase positive, catalase positive. So I know you guys will be wondering, how do you remember all these, bacteria in regards to oxidase positive bacteria, catalase positive bacteria? There are quite a few mnemonics on the internet. If you search oxidase positive bacteria, it will come up with quite a few mnemonics. Catalase positive bacteria, urease positive bacteria. So if you have them, you can share on the group to be very, very helpful. Because they can ask a question and they say the bacteria is urease positive. Then they tell you, name 2 other bacteria that are urease positive. Okay, so I think those mnemonics are really important. Do any of you have one that you can share with us?
I have a question.
Mhm.
So can we really see if it's motile under microscopy? Like, won't we? I thought we can't see if the bacteria is motile under microscopy, and we need some other stain.
I've seen here on regards that motility under a microscope, it's saying that there are some special, wait, let me read. It's saying here, there are some specialized staining techniques you can use. If you are to use a wet mount, a drop of bacterial culture is placed on a slide and covered with a cover slip. The slide is then viewed under a microscope. Then you can see the motility. Then the specialized techniques are things like dark field microscopy. Those ones are for treponema. That one you will see. That's what
Okay.
yeah. But if you are to do like a proper gram stain, you would see, because gram stain, by the time the procedure of gram stain you've done, you know, adding iodine, adding the safrarin, all that, the bacteria will be dead. It won't be able to move.
Okay.
Maybe I can share a link, because it's called wet mount motility test, and it's done under microscopy. Okay. Let me share the link with you guys so that you can read on that. But that's subject to confirmation. Okay. Did anyone have a mnemonic on these urease positive, oxidase positive, catalase positive organisms?
I have one.
Okay, yeah, sure. You can share with us.
Okay, let me type it.
Okay. In the meantime, we can be continuing. You've typed it? Okay.
Yeah.
P chunks. So that's for?
The small letter E's are not like, they're not any bacteria, but the P is for Proteus, C is for Cryptococcus, H pylori, U ureaplasma, N nocardia, K is for Klebsiella, S is for Saprophyticus, and the other S is for Epidermidis.
This is urease positive?
Yeah, urease positive.
Urease positive. Oh, okay, wow, thank you. I'll even use that. P chunks. Do you have for oxidase positive? Who has for oxidase positive? Can you share with us? Okay, I think if you can get, you can just send it on the group. That would be good. Okay, so here we have identified the results on triple sugar ion agar test. This is TSI. Then 4 clinical infection caused by the above microorganism. Identified 3 virulence factors that help the organism evade the immune system. Okay, so TSI is another one. I feel like anywhere you go, you have to know this TSI. You have to know this TSI. I can send you one. I remember during my second year, I had like a way of knowing this. I can send a picture on the group for all this TSI, but in relevance to Pseudomonas, it's usually alkaline slant, alkaline but, no gas, no H2S. Okay. Alkaline slant, alkaline but, no gas, no H2S. So pink, it will appear pink. Okay. Then the clinical infections caused by the above microorganisms. Here they are. Osteochondritis of foot following puncture wounds, running shoes, hot tub folliculitis, swimmer's ear, acute otitis externa, conjunctivitis in contact lens users, pure hygiene, or if lenses are worn for extended periods, malignant otitis externa in diabetics, meningitis, post-trauma or surgery, sepsis, meningitis, endocarditis, pneumonia, UTI. So quite a lot. So identifying 4 would be easy. Just look at from head to toe in terms of what it causes. Okay, so these are directly from your notes. And then the virulence factors. So here they are, starting from the outside. So structurally, we have the capsule. Capsule is always antiphagocytic. Pili, which is anandesine. Lipopolysaccharide, endotoxic activity. Pyocyanin, these are the, what are they called? The pigments it produces. Impairs ciliary function. Then for the toxins, toxin A, toxin S, leukocidin, elastase, phospholipase C. Toxin A inhibits protein synthesis, endotoxin S, protein synthesis. Leukocidin disrupts leukocyte function. Elastase disrupts tissue with elastin. Phospholipase C, heat labile, hemolysin. Okay. Let me send you guys the one for TSI because it's very, very important, especially in sport. They will ask quite a lot of questions on TSI.